But then I went to the washroom and did the morning walk. It was so far. So, like Dr. Aman, and I am not Dr. Aman. I have never been in PGI. So I am basically a physician. And I have tried my hands at different things, at teaching, as an investigator in studying, and so on and so forth. So whatever I am presenting right now is what I have learned about diabetes. These are hard-hitting messages, but very simple cases. And I want all of you to interact. So if possible, please, all of you from the back, please come forward. I want you to interact. Please, 30 milligram person. Now my question is she diabetic? Yes. Those who are in favor say yes. Please raise a hand. Don't inhibit yourself. Please raise a hand. Yes. And those who say no. And those who say maybe. Pretty good. That's pretty good. Right. Why do this? There were so many people who said no, maybe. Why? Good. So the point was that there are, in an asymptomatic individual, we require more than one reading. So what test to be done now? Postprandial. So some say postprandial. HbA1c, very good. Okay. So in this case, A1c was done, right? And it was 5.7. Now what to do? PP. Now, one test says that she is pre-diabetic. This test says that she is pre-diabetic. But the fasting says that she is diabetic. Now, what to do? OGTT.
Lifestyle modification.
No, we have to diagnose first. We got to give this patient a label and then advice. So the advice cannot be given unless you give him a label. So you have to give him a label. Is he all right? Is he pre-diabetic? Is he diabetic? Right. So let us review the guidelines as to what the guidelines say. We continue to do as we like to do because there is no one sitting above us. There is no MCI looking at our prescriptions. There is no Dr. Sodhi looking at our prescriptions. There is no API looking at our prescriptions. So we do whatever we do. But we should know what we should ideally do. Well, we all agree that in an asymptomatic individual, there has to be 2 readings. So if we have done one, ideally, and it will be found to be high in diabetic range, ideally that should be repeated. Different ones should not be done. That should be repeated, right? And if we repeat that, and if the 2 tests are discordant, that means one is saying something else, other is saying something else, we have to repeat the higher test. The test which is saying that she is a diabetic, that test has to be repeated, right? So that is as far as the diagnosis of diabetes is concerned. But please remember, don't use A1C in India for diagnosis of diabetes because we do not have NGST certified methods. All laboratories are using different kind of techniques and they are not yet actually certified. They are not just standardized. In America, they are all standardized. So it's all right for an American Diabetic Association to say diagnose diabetes by A1C. But I will not diagnose diabetes in India by A1C. The best way to diagnose remains OGTT. Because if you just get A1C done, you miss about 1/3 patient. If you just get fasting done, you miss 1/3 patient. So for a complete coverage, if you want, you have to get OGTT. But OGTT is not very easy to do. It's not in everybody. So next case, they are very simple cases. A 52-year-old obese individual presented with polyuria, polydipsia. He had symptoms. Now this is a patient who has symptoms. And blood glucose fasting was 200, postprandial was 315. Easily in diabetic range. So we diagnose that the patient has type 2 diabetes. What treatment to give?
What is his weight, sir?
Huh?
What is his weight?
I won't tell you. I will tell you what I want to tell you. Sorry. So what treatment to give to this person? And ADA says all kinds of things. It says start with metformin. So what treatment to give? Metformin, insulin, gliptins, or more tests?
More tests. Preferably insulin. More tests.
Insulin, one says insulin, other says more tests.
More tests, sir.
Metformin? How many say metformin? Oh, it's a, here goes metformin. So, metformin. Please, this is the quotation which is very close to my heart because that's how I practice. I practice simple things. Sometimes when I consider the tremendous consequences which come from little things, I am tempted to think that there are no little things in life. This is Bruce Barton, a Republican House representative from New York. And just think about it. If in your ICU you start washing hands after each patient, it will prevent enormous amount of infections in your ICU. So little things are very, very important. And we, on an average, we miss this little thing when we treat diabetes. You cannot write a prescription in this patient unless you have done urine ketone. Unless you know urine ketone, don't write prescription. This is criminal. So we have to ask for more information. That was the correct answer, that we require to know more information. But why do we not do that? I have seen many of our patients, our doctors behave in this fashion. A patient comes to him with a 300 blood glucose. He's right on the treatment without even asking for urine ketone. Why do we do that? We do that because ketosis is not very common in type 2 diabetes, but it is not very uncommon also in type 2 diabetes. We require 1/10 the amount of insulin for preventing ketone than for controlling blood glucose. So we require very, very little, minuscule amount of insulin to prevent ketones. And most of the time, type 2 diabetic have that kind of insulin in his body. But in special situations when the type 2 diabetes is under stress, infection, sepsis, MI, this, that, his requirement becomes much more, and there is huge relative deficiency, and that's the time when a type 2 diabetic can also have ketosis. And look at this study which says 20% of patients of ketosis were actually type 2, not type 1. So it is not very uncommon. And even your blood glucometer actually suggests that. When the reading in the blood glucometer is 360, it will say urine ketone, urine ketone, urine ketone. It will start suggesting that, but you don't get it done. Next case, simple case. A 15-year-old executive, not Modi, this is just to excite you, has diabetes for 4 years, is on diet, exercise and metformin 1.5 gram per day. A1C is still 9.9. Many of our patients come back to us with this. What should be added now as a second drug, right? We give you options. Sulfonylurea. How many people think sulfonylurea should be added now? Be open. Yeah, many of us write that, sure. Gliptins. How many of us think now is the time to add gliptins? Yes, some are doing like this. Then I like to do, but I'm not sure. Right. Insulin. Yes, now of us. Alpha-glucosidase inhibitor, which is another one. SGLT2 inhibitor. SGLT2 inhibitor, there are some at the back, right? They are saying SGLT2 inhibitor. Yes. What is our consideration? Now, there could be more than one answer which are correct. In clinical practice, it's not one answer which is correct all the time. But I want to drive home my point that what are you thinking? What is your consideration? When you are trying to think about a second drug, what are your considerations? Your consideration should be the most important one, other than the cost, the side effects, and so on and so forth. Will it be able to fill the gap? What is the gap in this patient? Huge. What is the rate? At least 7, if not less than that. Then 7 and 9.9, the gap is 2.9. Will your prescription, the drug which you are going to write, will it fill this gap? Or what you are writing is a recipe of failure. The patient will come back to you after 3 months and say, I'm still not controlled. So that means we must know how effective are our drugs. And this is what the effectiveness shows. All of us know that insulin will do the job at whatever level. It's very, very effective. Sulfonylurea are also very, very effective. They will reduce by about 2. Metformin is already taken. And of course, if he is not following diet and exercise, that can also reduce A1C to some extent. If we add LCA-2, it will bring it down by only 1. If we add gliptin, it will only bring it down by 1. So from 9.9, you will come to 8.9. How do you bridge the rest of the gap? So either you have to add 2 drugs at one time, or give more potent drugs like insulin, etc. So that was my viewpoint. That look at the gap and whether your drug will be able to fill that gap or not. Right. This is another common presentation. You know, Mr. SD, he's a 35-year-old businessman, is a diabetic for 2 years, is on metformin 2 gram per day. Good doses of metformin. Blood glucose fasting is 100, postprandial is 140, A1C is 6.5. Are you satisfied with this control? He comes to you and says, Doctor, these are my reports. Are you happy? Are you satisfied? So, those who say yes, please raise the hand. Yes, most of us are satisfied. Those who say no, please raise the hand. And those who say not sure. So I'll just ask you, sir. You say no. What are you not satisfied with this patient?
A1C should have been less.
This is A1C is 6.5. Do you want it to be 6? Okay. And what is your thought process? Oh, amazing. That's where I am in. Great. So let us see. Why we are treating the patient? We are treating the patient to bring down the blood glucose, or we are treating the patient to prevent him from dying? Which is more important to us? So we want to prevent and control the complications. What are the complications? The diabetics do not die of diabetes. They die of cardiovascular disease and stroke. About 70% of diabetics die of stroke and cardiovascular disease, heart disease. They don't die of diabetes. So even if you control his blood glucose well, what the hell are you doing? You're not preventing his blood glucose, his death from cardiovascular disease. So what is more important? Look at this. The definition of diabetes currently is so different. Look at this. He says diabetes is a state of premature cardiovascular death, which is associated with chronic hyperglycemia and may also be associated with blindness and renal failure. So diabetes is not blood glucose. It is premature cardiovascular death. And this is not what I'm saying, right? So that means we got to prevent this. And there was no better study than Steno-2 study, which was just study done on 160 patients, just 160 patients, and became a landmark study to tell us as to what we should do in a diabetic. But it was followed up. They were followed up for 13 long years. And you know, look at the difference in mortality in the control group. And you know, the death from cardiovascular disease came down, the stroke came down, myocardial infarction came down. And next slide is an eye-opener. It will tell you what controlled the death in these patients. Look at that. The lipid-lowering therapy accounted for more than 70% of the cardiovascular risk reduction. It was not A1C which helped. It wasn't blood pressure which helped. It was lipid reduction which helped. So please, for God's sake, don't be satisfied with the management of your diabetic patient unless you are keeping his lipids down, because that's what's going to prevent the cardiovascular disease and mortality, not your A1C. I'm not saying that don't control A1C. It has to be controlled. It has to be a holistic control of all these. That was one message.
Sir, lipid levels are not so important. Every diabetic should be put on lipid lowering drugs irrespective.
I absolutely agree with you that absolute levels of LDL are not important, but they should be given drug for lipids. If you are not giving drugs for lipids, then it is not, it's not good. So if you don't know where he is and what is he receiving, you are right. You have a point there. You have an absolute point. I agree to that point.
Your questions are also incomplete.
They are tricky.
Your questions are also incomplete.
They are tricky.
You don't give the cholesterol figures before deciding decision.
I have to hide certain things to make my point. I appreciate your point.
The message is not clear then.
Okay, the message in this part is that one should not be satisfied with a patient of diabetes unless you are treating his lipids, unless you are giving him statins. That's the message. I hope that is clear now.
Not only lipids. He is hypertension also. Hypertension will kill him more than the diabetes.
We said that. I will come back to this. Now, in this case, I was talking about steno-2 study. In this case, the benefit which occurred with decrease in the systolic blood pressure was only 20%, while the benefit which accrued because of lipids was huge, about 70%. So this was the message of steno-2 study, not my message. Okay. Next one. Mrs. M, who has a diabetes for last 8 years, is on metformin 1 gram BD and human insulin mixed start 30/70. Usually we give it 12 units in the morning for breakfast and 10 units before dinner. Her blood glucose fasting is 126, which is pretty well controlled. Her blood post-lunch is not controlled, post-dinner is not controlled. Her A1C is slightly high. Now, what should we do in this situation? Should we switch to 50-50? Should we switch to gliptin or should we switch to that no mix? Should we add alpha glucosidase inhibitor? Let's see. What are the options? Switch to 50-50? So some of us say switch to 50-50, which may deteriorate the fasting a little bit more. Add gliptin. Add gliptin. No one will add gliptin at this stage, which is a wonderful drug for postprandial. I am very surprised. Amazing. Okay. And switch to Novomix. The designer insulin? No. And add alpha glucosidase inhibitor? Lot of us will add this. That's pretty good. Right. There are a few points I wanted to make here. One is that Indians consume more carbohydrates. So alpha glucosidase inhibitor drug will be a good drug to use in controlling postprandial blood glucose. That was one. But more than that, I wanted to say that when pancreas was discovered, we discovered these beta cell and alpha cells. Because of insulin, we forgot about the alpha cells. And alpha cell functions are as important in progression of diabetes as beta cells. And this is what it is. In a postprandial state, the hepatic glucose output has to be brought down. And how will it be brought down? Only when glucagon level will go down. In diabetics, this doesn't happen. The glucagon level doesn't go down. So, we got to give a drug which brings down the glucagon level, and gliptin is a good glucagon drug. I'm skipping a couple of slides because Dr. Sodhi says I've got to hurry up. So, this is Mrs. DK, 54-year-old, history of diabetes for last 10 years. The annual investigation showed hemoglobin 9.4, MCV 85, creatinine 1.3. Her urine routine and microscopic examination is normal. Her urine albumin was negative, including albuminuria. Is the kidney normal or not? I go back. Creatinine is 1.3, hemoglobin is 9.4, MCV is 83. Is that kidney normal or not normal?
No.
So those say no, let us see no, right. And those say yes, normal, right. So please don't do it unless you calculate creatinine clearance. That's when, look at this creatinine clearance of 1.4, and in two different individuals, when you calculate creatinine clearance, it will be very different. So with a creatinine of 1.4, this young man of 32 years has a creatinine clearance of GFR of 62, while the second patient of 75, same creatinine clearance, same creatinine, has a creatinine clearance much lower. So please calculate. You must have an app on your iPhone, on a phone, which can easily calculate. This is the app with which you can calculate. And her creatinine clearance, or EGFR, was 45. And all of us are aware that EGFR of 45 means she is at stage 3 chronic kidney disease, right? So she has a kidney disease, definitely. The second question is she a diabetic kidney or is she has something else? So those of us who think she has got a diabetic nephropathy, please raise the hand. Is she diabetic kidney or is she something else? Was negative. I told you about that. Is she diabetic kidney? Yes. So few of us. Is she? And no. Right. So let us have a knowledge about diabetic kidney, it classically occurs, develops in 20 years. Onset is usually marked by glomerular hyperfiltration, followed by micro and then macroalbuminuria. GFR remains stable until proteinuria and then falls progressively. But that is classically seen in type 1, not in type 2 diabetes. Look at the data. In UKPDS, amongst CKD patients, 50% did not have albuminuria. So 50% patients who already gone into CKD did not have albuminuria. In advanced study, 2/3 of the patients with CKD did not have albuminuria. So still she can have CKD because of diabetic kidney. And there is a renewed interest in diabetic kidney disease without proteinuria. There are some recent publications and they have hypothesized why should it occur. They sometimes will say it is an atubular glomeruli, tubular damage is there, so it doesn't show in the urine, but this is just hypothesis. I won't go into the details for the paucity of time. So, diabetics, type 2 diabetics can have chronic kidney disease without proteinuria, so always get their eGFR done. When should you suspect other kidney diseases? Then diabetes, when it occurs early in the course of the disease. The patients had type 2 diabetes only for 1 year and is now showing CKD. There must be some other cause. If there is no retinopathy, you have done fluorescein angiogram as well and there is no retinopathy, you should suspect there is some other cause. And when there is active sediment in the urine, that means there are pustules, there are RBCs in the urine, then we should suspect other kidney disease. And of course, needless to say that all diabetic kidney patients must be given ACE inhibitors, whatever their serum creatinine is, one must take care of the potassium. Last question, in hypoglycemia, what is the body's first response? Is it glucagon? Is it catecholamine? Is it growth hormone? Or is it something else? First response of hypoglycemia in a patient. What happens? So some of us feel it's catecholamine, glucagon. Some of us feel it is glucagon. Okay, I go. Well, definitely it is glucagon, but before glucagon secretion occurs, something else occurs. Okay? The glucagon secretion, the most potent stimulant of glucagon secretion is decrease in the insulin level because beta cells and alpha cells, they talk to each other. And even the blood flow is from beta cell to alpha cell. And so, what happens in hypoglycemia? In hypoglycemia, the first response is not glucagon, but decrease insulin. Stopping insulin production is the first response. And that stimulates glucagon. And that causes glycogenolysis and normalization of glucose. What happens if this first response is not there? If hypoglycemia occurs, but there is no insulin, the patient is insulinopenic, the patient is long-standing type 2 diabetic who doesn't have insulin now in his system. So what will he suppress? Nothing. If he cannot suppress insulin further, he cannot stimulate the glucagon secretion to that extent as it should have been done. And that's the message, that those type 2 diabetic who are long-standing type 2 diabetic, who have very little beta cell left in them, are actually more prone to very severe hypoglycemia because of this, that they cannot suppress insulin. And because they cannot suppress it, there is no insulin to be suppressed. And so the most potent stimulation of glucagon secretion doesn't occur. And that's what happens. Thank you very much. And the 56th verse of Paul says, those who know